My name's Chris Dacey. I'd like to just tie together some of the comments and statements made by the various disciplines presented and offer a perfusionist perspective. In full disclosure, I am an employee of LivaNova. However, I'm going to be discussing my professional background and my experience as a perfusionist and an ECMO coordinator, and won't be discussing any products I represent. I realize this is probably a smaller slide for your perspective in the room, but I think it's really critical if we want to break down, looking one layer up from what Dr. Abu Salem and Dr. Najam mentioned in terms of how you construct a program that can actually address this patient population. And most importantly is the construction of the program in and of itself. So this publication came out earlier this year from Inova Fairfax talking about the combat approach to cardiogenic shock and a full commitment to avoiding preventable death in cardiogenic shock. But the important thing is having clinical goals that leverage rapid identification of shock and hemodynamic criteria, early mechanical circulatory support, and use and low thresholds for right heart catheterization and echo. Okay, there's centers that have an appetite or a low threshold for right heart catheterization or echo are able to identify shock earlier and intervene earlier. Also understanding what shock criteria is and having a universal definition of shock. Just a show of hands, we saw in the last slide cardiac power output. Who's familiar with cardiac power output and what that is, what the definition of cardiac output, power output? Some, not all. Worth noting, right, it's a very simple calculation. It's mean arterial pressure times cardiac output divided by 451. Sometimes you can round that off to 450 if you need to remember it easily, okay? And then how about the POPI score? Has anybody heard of the POPI score? Pulmonary Artery Pressure Index, which is a very reliable, sensitive measure of RV failure. It is the systolic PA pressure minus diastolic PA pressure over right atrial pressure. If you commit two things to your memory out of my presentation, maybe it's just those two elements, which is a good appraisal of left-sided function, right-sided function, all derived from a right heart cath. So, the identification of patients comes after you've constructed a program that's committed to hemodynamic monitoring, in as much as vital signs, EKGs, and labs, but that low threshold for right heart cath and echo. Then the interventional phase, or the escalation of therapies, where you assess hemodynamics, appraise what's the appropriate therapy or intervention that needs to take place, and continually reassess. Then the recovery and de-escalation phase, probably where most people fall flat, is understanding, okay, we figured out which patient needs support, we've determined the intervention in the course that we're going to take, we've done it in a team-based manner, but what do we do now? And using hemodynamics to drive your therapy and collaborating with care centers that might offer advanced therapies, transplant, devices. But probably most importantly is the continuous quality improvement initiatives, analyzing your practice, making sure that you're understanding, are you doing the right thing, right? Just treating patients and just using devices doesn't necessarily mean you're treating and treating the population at need. So this is a slide that I've sort of manufactured, and it's a work in progress, but you know, my contention is the perfusionist sits sort of in the middle of this Venn diagram. They can contribute to a diagnostic and an interventional identification team, figuring out which patients actually need support because we have an advanced understanding of hemodynamics. We can be part of the interventional and primary therapy team because we have an advanced understanding of the devices that are needed in this population. And then the management and troubleshooting is in our wheelhouse as well because those devices are in our pocket, we generally command, and we're the gatekeepers of them within an organization. So what is our role, okay? Well, I think helping identify cardiogenic shock is the pathway to supporting these patients, especially in the context of some of the recent valve trials that came out at ACC, right? If we're gonna be seeing TAVR being used in low-risk populations, we might be seeing less surgical cases and more need for our presence in the ICU, in the cath lab, in the ED. Again, I apologize if the print is small, but I can give you some takeaways here. You don't have to wait to get to the cath lab. Bill O'Neill's group published this in JACC earlier in 2018. It's the responsibility of EMS in the emergency department to look and to activate multidisciplinary teams if they see signs of shock. And how do those teams get well acquainted with what to look for and what devices they should be considering? Well, a perfusionist can be an educator and can be a very, very important educator in the setting of a medical center or a medical system. So, my message to you is start to think about your role outside of the OR and outside of the heart-lung machine. Using a multidisciplinary team to actually arrive at what the appropriate therapy is if you identify shock, and using consistent shock indices, having a protocolized approach to shock with a universal threshold, especially within a medical system. If you're working with a hub and spoke network and making sure that the smaller community hospitals can refer to you with a patient early enough. To Dr. Abu Salim's point, early intervention doesn't necessarily always happen in your lab, in your OR. It might happen at the patient at the time of presentation at the center before they come to you. And most importantly, the post-interventional care, making sure that you're using hemodynamic drivers to guide your care, and if you need to continue to up-escalate therapies. So Kapoor and Esposito and the colleagues in the shock working group, I think, do a great job talking about hemodynamic problems and intervening before they become hemometabolic, really breaking it into to 4 different focal points. The concept of circulatory support and systemic perfusion, in as much as oxygen delivery, okay, maintaining mean arterial pressure, and then looking for end organ function to talk back to see if you're delivering enough flow. Then the ventricular support, or using tools to optimize LV and RV unloading. What sort of variables you use to quantify that quality of unloading, and then what sort of measurable feedback you can get, the rate of tachyarrhythmias or BMP. The quality of coronary perfusion. If you don't unload, your transmural gradients are sacrificed and suffer, and it doesn't matter how high your MAP is if your end diastolic pressure is really high, okay? So ST changes and enzymes that are feedbacks in that pathway. And probably least appreciated, but it's becoming more and more prolific in the contemporary literature, is renal and hepatic unloading, so central venous pressure, okay? Do you have good quality unloading of the kidneys and the liver circulation in order to optimize creatinine LFTs and resolve potential coagulopathies? So if you wait too long on this pathway, it can be difficult to reverse a hemometabolic problem, but if you can identify a hemodynamic problem, that's the time of intervention, and that should be your trigger for early intervention. So, we appreciate, especially in the VA realm, it's a bridge to somewhere, right? It's a tool that should be used constructively for a bridge to transplantation, recovery, durable implantable devices, or at least a dignified decision, okay, to give you time, potentially in a multidisciplinary cohort, in a setting in the light of day, to figure out what is the best pathway for these patients. And obviously, VA ECMO gives you the luxury to support a whole host of different pathologies. But maybe some of the most compelling evidence to come out recently with the Mass General group, talking about how the improvement survival advantage from 37 to 52% was due to a transition to a multidisciplinary care model, incorporating perfusionists and decision-making processes. And this multidisciplinary team approach to ECMO has played an integral role in the success and survival to discharge in this population. And it's interesting and worth noting that they saw the distribution of types of cases change pretty profoundly in that period. More VV cases, less VA cases, probably because the patient was getting the support that they needed in the type of intervention that they needed, as opposed to just a shotgun type approach. So I thank you for hearing my perspective. I think we're going to take all the panelists.